The broadcast is now starting. All attendees are in listen-only mode.
Good evening, everybody. We're not getting started for another 30 minutes, but we do have a few people online already, so we're just doing a quick sound check to make sure you can hear us okay. If you can just let us know that you're hearing us by typing yes into your chat box, that'd be great. Thanks. Good evening, everybody, and welcome to this evening's New South Wales Coronavirus Update webinar. We are joined by a combination of speakers tonight from both RACGP and the New South Wales Ministry of Health. From the RACGP, we have Dr. Charlotte Hespy and Dr. Penny Burns, and from New South Wales Health, we're joined by Kerry Chant, Kathy Dempsey, and Tanya Sorrell. So thank you to our panel for joining us this evening. Before we start, I would like to make an acknowledgement of country. So we recognise the traditional custodians of the land and sea on which we live and work, and we pay our respects to elders past and present. Okay, so I'll hand over to you now, Kerry, to start us off for this evening.
Can I welcome everyone to the webinar and extend my appreciation for you joining us this evening. I thought what I'd do is run down on a little bit of a quick overview of where we are, and then ask Professor Sorrell to just comment on any new emerging information that's since our last webinar in relation to the novel coronavirus, and then finally quickly hand to Kathy Dempsey, who can go through the infection control, because we clearly need, that's a key piece of information that GPs will need to be armed with. So currently we remain at having four confirmed cases of novel coronavirus. As I indicated previously, those patients have been now discharged from hospital and are doing well. So that's, I think, demonstrates that recovery, that the majority of patients recover. We've also learned that the disease can have many forms, including a milder form. And that's not to, we also need to take it seriously, because there is still a significant mortality rate reported overseas, and we're hopefully getting some more information about those estimates. In terms of what we're currently trying to do, is we're currently trying to contain the spread of the virus, while we are watchful about what is happening in China and what is happening overseas. We have asked you to broaden the case definition, and we're really pleased to acknowledge the level of testing that has really increased to our emergency departments, but also primary care, and I just want to acknowledge that. That's really important, because we know that, notwithstanding originally we were directing everyone to our emergency departments, we know that GPs are an important way in which people engage with healthcare, and regardless, that's often where they'll feel most comfortable in accessing care. And at this time, when we don't want to miss any cases, we really want people to be accessing care and getting diagnosed, so we can take those public health messages, isolating them and quarantining contacts. You're probably also aware that there's been a number of border measures put in place, so that we are screening all flights returning from mainland China, and also reviewing people that have exited mainland China in the last 14 days, even if they're arriving on other flights. They've been asked to self-isolate from 14 days after they've departed mainland China. In addition, the Commonwealth Government has instituted a number of border measures whereby only Australian residents or their dependent children or spouses are allowed to enter the country, and that has meant that there's been significantly reduced numbers of people coming from mainland China. We continue to monitor the progress of the virus, and I think at that point I'll defer to Professor Sorrell to actually just give us an update on what additional information we know about the virus, its behaviour, its incubation period, its morbidity and mortality profile, and then we'll hand to Kathy Dempsey.
So I'd like to perhaps just reiterate a few things. At the moment, we're still sticking with the 14-day incubation period. There is increasing evidence, but it's predominantly from China, of course, that the average or median incubation period is of the order of 5 to 6 days. In Sydney, we've had one case with a 10-day incubation period, and I think it's perfectly reasonable and desirable that we retain that 14 days just to be sure that we're not likely to miss any late presenting cases. The second point I'd like to perhaps remind you of is that the mortality rate that we're measuring at the moment really represents predominantly hospitalised patients and therefore patients at the more severe end of the spectrum. There are various estimates of that mortality rate. I'm still hearing around 2%, but recognising that certainly in China, the vast majority of milder cases are unlikely to be diagnosed or potentially even come to medical attention. My opinion would be that the overall mortality will be substantially less. What we can say is that with the figures we have to date, it's certainly less than what we saw with SARS, or significantly less than we're seeing with the other coronavirus MERS. I'd like to again emphasise the point that where mortality has occurred, it tends to be in the older patient. I won't say the elderly, as I number myself in the older patient category, but also that's the group, of course, who have significant chronic disease or comorbidities. So I think it's important in that category of patient to take particular care. The other information, I suppose, that's relatively recent relates to the diagnostic tests and our ability to perform them rapidly, but not only do that, be quite confident in our diagnosis. You will have heard on previous webinars Professor Dominic Dwyer and Professor Bill Rawlinson talking about when you've got a new virus and a new test, excuse me, it takes some time to actually validate it and have an understanding of how sensitive and specific it is. With us in New South Wales now having cultured the virus from 3 of our patients and been able to determine its genetic sequence, this really makes our confidence in our tests and the confirmatory tests that much higher. So that this is a very good news story.
Thanks. Kathy, would you like to just cover off the infection control?
Sure, thanks, Kerry. So I think it's important to understand that with any emerging or new pathogen, from an infection control perspective, we always look at adopting enhanced precautions. So hence why we adopted full airborne precautions when we first saw coronavirus emerging. What happens over time is that once we start to understand further the information and that information evolves, we target those precautions based on the mode of transmission as we understand it. So for routine practices with coronavirus, it's contact and droplet, and understanding that standard precautions are your basic first line tier. So that's understanding that you take precautions for any potential exposure to blood and or body substances. Contact is applied based on the contact that you have with the patient, and droplet is based on your potential exposure to droplet. So for any routine care, it is contact and droplet. And then for any procedures that are called aerosol generating procedures, because there is a risk of greater exposure to droplets, so there's more sort of possibility of droplets circulating, then we add airborne precautions to those. On top of that, if a patient was critically unwell, so that's highly symptomatic, and they're usually patients that we would send into hospital, then we would adopt airborne precaution, which is the addition of the P2 mask. So the difference is contact and droplet is surgical mask, and your airborne precautions are P2 and 95 masks.
So tell me, so for me, I'm a GP, I'm in the room, I have a patient who has already alerted my reception staff that they are concerned that they might have coronavirus. They've been given a mask and they've been put in the isolation room while they're waiting. They then come into my room, and on history taking I confirm that I think they need to be tested. So once they've gone, what do I actually need to do? So they've come into reception, they've been in our isolation room, and they've been in my room. Yeah. But they've had a surgical mask.
Yes. So then realistically there's been little to sort of no environmental contamination, maybe some touching. So then I would be cleaning the hard sort of frequently touched surfaces with a detergent or a combined detergent and disinfectant wipe. So at the moment we're likening it to, if whatever you're cleaning after a gastro would more than be efficient for coronavirus.
And Kathy, then I want to see another patient in that same room. Do I need to wait half an hour, or am I able to take them straight in?
So you should be able to take them straight in. So the only reason that we would leave a room vacant for any specific time is if we think that there's been aerosolization of particles. So if you had performed an aerosol generating procedure, of which we've determined that probably wouldn't happen in the GP. Or someone who was critically unwell, who didn't have a mask on, then you may consider, if they were in there for any specific time, that you may want to rest the room for around about 30 minutes.
Okay, so we'll just go to that we don't think we're going to generate any aerosols in the GP room. If I'm a country, sort of outer urban GP, and it's quite a trip to the nearest private pathology and or accident emergency, and the patient is really insistent, can't you take the test for me? And I've taken swabs before, so I go, okay, what are the things that I really need to be mindful of? And I will say that at the point of doing the nasopharyngeal, they do a cough.
So I guess there's a couple of things that you need to risk assess, and that's the likelihood of exposure to droplets. So a mask would need to be a minimum, so a surgical mask in that environment, plus or minus some goggles. But again, it really depends on positioning and how you position that, how well you're able to take a swab. Usually on baseline recommendation, we would say a mask and goggles at a minimum and a pair of gloves.
Okay, and how long now does my room need to be? I mean, what do I need to do anything different
I
in
would
my room?
still not rest that room, because to infection control, that would not be an aerosol generating procedure.
Great, thank you, that's good. I mean, I still think that as a GP, it's much better that I send them to either the private pathology lab or the emergency department, depending upon what availability and et cetera is around. On that front, to Kerry, in terms of checking what private labs are doing it, you've got a good list for us, don't you?
That's correct. On our New South Wales Health website, there's a link through to the private pathology, because what the private pathology have done is identified those facilities that are actually able to do the testing, and that might be a factor of having a waiting room area where they can rapidly move the patient in and not impose impact on any others. It might be where they've got staff that are trained in wearing their PPE and where they've got the appropriate infection control. So go to the website and there's a click through, and each of the private pathology companies are listed there, and you can click through and see.
Do they do it in an alphabetical order?
I actually haven't clicked through, but I will follow up and hopefully they do.
I think it is pretty alphabetical. I mean, one of the things I would recommend, we use a couple of different labs, And I've spoken separately to each of these labs, and they have slightly different requests and requirements. So I would recommend ringing your lab just once and just finding out where the collection settings are, which most of them are listed on the site. But I'd actually double check that your local collection centres were actually doing it, and I'd find out exactly what swabs and what they wanted to be written on there. And in general, we're going to be testing not only for coronavirus, but we're going to want to test for multiplex respiratory. Because we're going to be wondering whether this person's got influenza A or something like that as well.
And I think you make a very valid point that this is also influenza season in China. And so we've been finding influenza in these patients, but we've also been finding RSV, rhinovirus, metapneumovirus virus. So the whole suite of respiratory viruses have been found. And as I said, despite testing around over 650 people, we've found 4 confirmed cases. So we found a lot of other respiratory viruses.
So on that front, are we going to bring forward influenza vaccination program if we know already that there's some influenza out there? I mean, we're only at the beginning of February and we've got that. Is there any opportunity for us to try and get on top of influenza early?
I think this raises a really interesting thing that we've seen, and Dominic Dwyer got asked this question in a session on Friday. And I think we're now realising there's a lot more seasonal transmission. So I think it does call into question our approach, and I think New South Wales Health also recommended potentially considering flu vaccine for those travelling to the Northern Hemisphere as part of the travel vaccination as well. And I think you do raise that point, but at the moment there isn't a window where we don't actually have vaccine because the way we cyclically do that. But as we learn more about the viruses and learn about their interseasonal spread, it does behove us to consider those factors. There's also, and I defer to Tanya, just thinking about the optimum time for vaccination to get the peak and whether we're actually, whether we don't want to, if people are only going to get one vaccine, we want to make sure that it comes at a time when they're corresponding to the peak immunity for them, given that the influenza vaccine doesn't produce long-lasting immunity. And particularly, I think all of us would like a vaccine that produces a longer lasting immunity. But Tanya, did you want to comment on?
I don't know that I have anything extra particularly to add, Kerry, except that we are, from research that's being done across Australia, recognising that there is summer transmission or inter-seasonal, as you called it, transmission of influenza. And we're trying to understand, is there something special about that virus, or is there something special about the environment or the origin of it? And at the moment, we really don't have the answers. In terms of the question about how early should patients be vaccinated, clearly keeping ahead of the curve, but I think the immunity would be expected to last sufficiently over the period of 9 months to 12 months, except in that group of patients who don't develop the adequate immune response that we expect from the majority.
So it's interesting because as GPs, when people do travel, one of the biggest things they pick up is flu. So the number one thing they come back with from overseas is the flu. And I guess we know that's interseasonal spread in the warmer areas. And in the last 2 years particularly, I've noticed a lot of influenza A across the beginning of the year. So yeah, I think it's an interesting question. We've got better stocks of influenza now in general practice because of the vaccination for women, and so I know ours are just about to expire soon, but we are getting a better sort of year-round coverage for influenza, which is good.
So I'll then sort of move back a little bit to the coronavirus. Today the news is all about the large number of deaths reported in one day in China. Now, I just want to decrease any panic that people might have arising out of that, given the large numbers that are also now being diagnosed in that area, that you would sort of have an expectation that therefore the numbers are going to be larger in terms of deaths, but it is still a very low percentage of deaths per numbers of diagnoses.
So obviously there's a lot of factors that, as Tanya said, one of the things that we often need to wait for is a serological marker for infection, because if we're actually going to figure out how many people have been exposed, our current testing is just based on testing people that have come forward to test. Whereas if we can test the whole population, we can find out how many actual people have got infected. So that's one of the factors, but we're still a long way off from the serological marker. So we don't have that key piece of information. Also, we know that some of the tests are accumulated and loaded. So the other thing is I would go back and find out whether that's just reflecting the fact that they've now notified a bunch, or what's the timing of those deaths. And so we have historically seen numbers jump around, and sometimes that's a factor about when there's been a bit of catch up in the data collection. Obviously, everyone's watching the data daily, and we're having regular meetings of the Australian Health Protection Principal Committee and also the Communicable Disease Network Australia that meet every day to pore over all the information, as well as reach out to CDC, the UK, Public Health England, to really bring the best intelligence and information to bear, as well as using the clinical contacts across various countries in equivalent sort of CDC structures to actually understand what's going on. Clearly, we also need to know what's going on outside China, and we're interested also in the countries that are reporting cases and the countries that are not. So I think I said in my first webinar that modelling data predicted that Australia would see some cases because of the fact that we had travel from Wuhan. Sydney had direct flights from Wuhan, and Australia is a popular destination for Chinese tourists. So on the basis of modelling data, we were expecting cases, and that modelling data showed that Sydney and Melbourne were probably the two sites where we'd have those cases. And the modelling data was correct. We were the two sites, and obviously Queensland's had a cluster, and as is South Australia. So the fact that we've actually identified those cases actually reflects the robustness of our health system and our ability to detect. So we're looking, our epidemiologists are looking at those countries where you'd also think, due to travel patterns, that they should be detecting cases and they're not, and that may raise some questions around what's going on in those countries, but also in other countries that are reporting cases, are they linked to a particular outbreak? Is it controlled? Have we got sustained transmission outside a limited cluster? And obviously for Japan, there's an argument that given that boat is quarantined, should they be actually accruing all those cases, because to some extent they're not even on mainland Japan, and those numbers will be increasing in Japan, but it doesn't reflect any risk of ongoing transmission because all of those people are quarantined. And similarly the case in the Queensland, all of the cases that were subsequently diagnosed were amongst a family group, so whilst there was no evidence of transmission, that presented a risk to the community because the transmission occurred prior to them becoming affected. So these are all of the data limitations that we've got to look at and understand and build a picture of what's likely to be occurring.
And just to add briefly to that, even though we've had quite a small number of cases in Australia, they've all been relatively mild. None of them have been severely ill. None of them have been anywhere near an intensive care unit. And so in some ways we need to wait for numbers to accumulate outside China also to be able to determine a mortality rate in a setting where there's a really good health service.
And also there's the international communities working together to collect information in a systematic way on the cases that have been identified out China as well, particularly taking every opportunity where the information derived may add to our understanding of incubation period, because in a setting where you've got a lot of infection, it's actually very difficult to tease out primary from secondary incubation periods, whereas the transmissions that are occurring, these cases that have originated from China, give us quite an opportunity to gather that data. As Tanya said, one of our cases has a very clear 10-day incubation period, and that's because they had contact with a case that was subsequently confirmed from a province which wasn't Wuhan, Hubei. So that's a very sort of clear epidemiology link, which gives us the 10 days. And similarly, when we're following up the transmissions in the other cases, we're sort of giving that picture that it's around 5 to 7 days is the median sort of incubation period.
So can I just ask a question? And recently in the UK, there's been a general practice that's had to close They were closed because they had 2 GPs that were thought to have been exposed and at risk. My question, I guess, is, and I'm getting that from a lot of colleagues actually ringing up and saying, what makes me exposed? So, we talk about a close contact with someone as being defined as 15 minutes face-to-face without any protection, or 2 hours within a room without any protection. So as a GP, what would have to happen for me to become a close contact and then have to exclude myself for 14 days?
So maybe I'll start and then hand over to Kathy. But there have been a very small number of GPs who have been impacted by this and through no fault of their own. And sometimes, as I think I've said in the previous podcast, histories change, information changes. So I don't want to attribute any issues to those GPs. So in cases where people have actually been fully exposed, the patient hasn't worn a surgical mask, where they've done a full examination, maybe taken swabs, those are the sort of circumstances where the person, and had a consultation for a significant period of time, all of those would mean that the GP is at risk, and therefore at the moment in the current settings, whilst we're trying to contain the spread of this, we take a very precautionary approach, and those that in that circumstance the doctor would be asked to go into home isolation for 14 days. Whilst in isolation, they can catch up on all of their CPD and other things. So, and the same thing for our healthcare workers if they inadvertently did that. But that would be the scenario. But Kathy, did you want to add anything?
Yeah, so from an infection control perspective, when we look at contact tracing, it's really around that sort of unprotected contact, so unmasked. So if the patient, we would do a risk assessment. If the patient was masked and the GP, for example, wasn't, then we may look at like time of exposure, what was done during that time. Definitely though, if the patient is masked and the GP is masked, then that by its own self means that there was no exposure because there was the correct protection during that case. And then obviously depending on what was undertaken, whether or not there was an addition of goggles or not. So we look at those at risk assessment as well.
Thank you. I think there's still a few questions coming around the sputum and collection of sputum. And I think my very basic understanding of this is that if the patients are mild, GPs, if they wish to, are welcome to do testing and to do nasopharyngeal swabs. Most people with mild disease will not be coughing and producing sputum, so in most cases there'll be no need to take sputum. If they are producing a lot of sputum, they're probably more unwell and they're probably coughing more and they probably need to be referred to ED after a phone call. So that would be my take on it. I would generally be just doing nasopharyngeal swabs. I probably wouldn't be doing sputum. Is that correct?
I think that's a reasonably pragmatic way forward, because what we're trying to message is sick patients are best managed in the emergency department. And that's because we're still trying to learn about this disease. I mean, we've had experience across Australia of 15 cases. We haven't seen, the acute, and even for them, there's been, of that subset of 15, there's been a couple that have had, some ups and downs in their trajectory.
Particularly in the second week.
Yeah.
Interestingly enough.
Yeah. So I suppose at the moment, and I think everyone probably needs to realise we are still learning, and I just want to reflect that, and so that's why these webinars are so valuable, because our comfort may be in 2 weeks' time after we've had further experience, or in 4 weeks may be a lot more comfort. So what I'm saying now is the best information I've got now, but it will evolve. So I suppose what we're also saying is if they're sicker, producing sputum, coughing up stuff, we would be concerned about their infectiousness more broadly. The other dimension of managing a patient is really can they safely be self-isolated at home? So the other thing I'd like to say to you is, even though we're saying you don't have to ring the public health unit, if your patient is a student, or if your patient is particularly a university student who's living on campus, we really would love you to ring the public health unit so that that person has, there can be arrangements put in place so that person can be safely self-isolate for the period of time whilst waiting for the results. And that would arise also with the doctor having made a risk assessment about if there's someone who's profusely coughing, how are they going to get to the centre to get the specimens collected? Are they posing a risk to anyone else? Is that safe? So whilst we're trying to learn more about this virus, we just want to take a bit more precautionary approach. So anyone who's sick and unwell, we're referring to EDs. But what we have recognised is that the disease can happen in a very mild group as well, and we're seeing that as very appropriate for GPs to assess.
Now, there's a range of questions, which I think is really worth clarification, is around the number of negative tests that you would accept. The questions are stated that there have been people who've had 1 or 2 negative tests and then have come back positive in China. And there was also sort of a question of, if you convert to negative, how likely is it that you can actually go back to being positive? Again, some of these are reports that are coming out of China. So how do we take that seriously? So if you've got someone who really has been exposed, has a negative test and has ongoing symptoms, is the one test enough to say they don't have it? Which goes to our specificity and sensitivity question.
There are a few ways I could answer that. The first, perhaps, to take if they're asymptomatic. So if they happen to be a contact and are being traced and they're asymptomatic, but at the 14-day period isn't up, then they still should remain in home isolation for that 14 days, and they may develop symptoms during that time and be tested and be positive if it's due to coronavirus. If you're talking about patients who do have symptoms, mild symptoms, and they've had oropharyngeal swabs, we are still learning about the test. We do know that with any form of viral pneumonia, if there is a pneumonia, the lower respiratory tract will have a higher concentration of virus. And we've had that experience with one of our patients where the concentration in the lower tract when he produced sputum was substantially higher than the concentration in the upper tract. When you're asking about the number of tests that need to be performed, I can't give you an exact answer, but 2 should be sufficient in our limited experience.
But I suppose the issue there is that, and I think Dominic got this question on Friday as well, is for the milder patients then that have got very mild symptoms where we're just trying to do it from a case finding perspective and they may well not have sought care otherwise. You know, I think we would think that the test is quite valid.
Oh, yes.
It's quite sensitive. And then the patient group that may be more problematic are potentially those ones that are requiring, you know, have the lower respiratory tract symptoms, and hence that's why referring them to the ED is important, because they need to be sorted out as terms of what they've got, and they may require more testing or a lower respiratory tract sample to actually do it, and you can't exclude it on an upper respiratory tract sample. So I think that's a consideration, that we would have more confidence in the accuracy in those that had the milder symptoms, but in the presence of pneumonia and perhaps at different phases in the illness, the testing.
So then clarification, so someone who's been sick, you've got a negative testing and you've sent them home, but they're doing a bit more coughing. How long do we need to keep them in isolation? How accurate, how happy are you that the negative is that they're negative and they're no longer transmitting virus?
The problem is we can always have 2 processes going on. So if it's within the incubation period and there's been a change, then they probably should come back and get reassessed for the utmost of caution, because they could be 2 different pathologies, and we don't have a lot of information coming out about the likelihood of having concurrent respiratory infections, but we know for other things that's
it can happen, and in the case reports there have been instances, not that we've particularly seen them in the few cases that we've had here.
Now, my next thing was just following up your comment about the countries that aren't testing that we would have expected that maybe do have cases. If we're looking at containment for Australia, are we going to increase the range of where people have been to where we test if they come in with symptoms that align with coronavirus. So, for instance, Indonesia and or Singapore, I mean, countries that we would be expecting to be seeing.
So there's actually modelling work that's being done, which is actually assessing a variety of things, including the data about where there's increasing case numbers and teasing out whether that's linked to a point source like the cruise ship or represents ongoing transmission in the community, but also looking at those where, based on travel patterns, you would have thought that they might have cases, and then understanding whether the health systems in those countries making a guess at whether they've got good surveillance systems set up. These factors will all be taken into account, and CDNA is actively considering about what our next step should be. UK has sort of got a list of countries that they've got that they're sort of saying be open to, and CDNA is currently looking at that concept. So I suppose at the moment
So we may increase the range of people that we're interested in testing when they come in.
That's right, because the question really becomes our settings, how long we're in containment. The objective is, can we eradicate this disease? MERS and SARS were effectively contained. The question ultimately is, can this virus be contained? Now, that will be a product of China, and China is taking a lot of steps to close down the transmission within China, but it will also reflect the other countries' capability should they have already been, the disease being introduced into those countries, and no system can be foolproof. But if there is evidence in other countries where there's community transmission, all of these have to factor into our considerations about whether containment in the long term is viable. But I would like to say, even if we move out of containment, and that's, we have to continually look at the data and provide the best advice to governments about what is the right settings. But if we should move out of containment, the clear message is that we will still be doing public health measures. So we know that from modelling data, asking cases to isolate themselves when they've got symptoms, contact tracing around the people at most risk and giving advice to family members or other close contacts about precautions they should be taking, will still have significant impact on flattening the curve and reducing the impact. So we will be having to reset and readjust our settings as we go through this.
So although it really doesn't address your point because we don't know the future, all of the cases in Australia so far have been directly linked to China.
I guess going on from that, and I know you can't model the future, but there's all this modelling going on.
Yes.
In terms of projection, is there any thought, like, I heard Brenda Murphy, I think, was saying that we may be at the peak, we may be curving, we may be not. Is there any sort of projection as to if we are at the peak now, how much longer we would be? I mean, are we talking about going on for weeks, months? Is there any sort of thought about how much longer?
So in terms of containment, I suspect we've probably found, we've either found the cases or not, because we've also done things like asked people to home isolate. So even if they had a mild disease and they home isolated and they didn't, they followed those instructions and kept others from being infected, then in essence that is effective containment. They haven't managed to pass it on. And so at this moment, we haven't had any demonstration of our cases transmitting it. And if anyone else that we may have missed effectively was contained through their own actions, and I'd like to just acknowledge the fact that the advice we've had is the vast majority of people have been, heeding that advice around self-isolation, then effectively we won't be seeing any more cases. And as I said, the cases that Queensland's reported are people that they've already had in hospital in isolation, and it's just because of prior contact before they were put in isolation that those cases are coming forward because of the lag in the incubation period. And so there's no evidence of transmission here. The real turning point will be how long, the border measures that are being taken, because obviously that's reducing the pool of transmission in. It'll be about what's going on in other parts of the world, because ultimately it's impossible that Australia, although we are an island, we also recognise we're in a global community, and if the rest of the world gets impacted, we can't keep it out. So I think we just need to, at the moment, be understanding we're strictly in containment and we're doing everything. And to some extent, it's really pleasing that we haven't seen any other cases. It's also reassuring that we've been testing a lot of people at the border that have been in mainland China and they're screening negative.
So the numbers you recounted yesterday were about 14,500 people have been checked at the airport, some 50 plus was sent for testing and all tests were negative.
So there was a question there about sort of exactly around that testing thing. So if someone does come back negative and just clarification and then develop symptoms, we would test them again.
Yes.
But they should have been in self-isolation in the meantime.
That's right.
If you have a pregnant patient who's been exposed, is there anything different in terms of advice for them? I mean, again, it's unlikely that it's going to have an effect on the pregnancy, but we obviously don't know anything.
I guess Professor Rawlinson has addressed this question and has indicated that coronaviruses are not teratogenic, for want of a different term. But, of course, if a patient has a very high fever during pregnancy, it can impact the pregnancy. So that's probably as far as we're able to say at the moment. Again, this is a new virus, but with the evidence we have about other coronaviruses, we would not expect that to be an issue.
We do understand that particularly pregnant women may be more anxious, and so having a lower threshold for testing and reassurance.
Sure.
And obviously if they develop fever, I think Professor Rawlinson indicated fever control was a really important aspect of it. So
Okay, so just him because he's an expert in congenital infections. Yeah.
So just back on, now I sort of semi-lost it, in terms of the testing for people who come in really worried but don't fit our current criterion, can we test them?
You can if you really, look, I think we were leaving it to your judgment. Obviously, we have to be prudent in healthcare expenditure. So if there was a real reason why there was some story that made you, a contact of a contact, like a contact, a direct contact or some link or some sort of reason, I trust GPs to, apply good judgment, but we don't really, it is wasteful of resources to be testing widely at this point in time. I'm sort of alerting to you too that we may change the advice of where we might look at and where in terms of countries, depending on, as I said, we're watchful of that information. So we just call upon you to be wise in your judgment. Clearly mainland China is the predominant country source of it. It's not to say that there can't be other sources. And we're also looking additionally at other sort of surveillance systems. So, for instance, we're sort of saying, if there's someone in ICU that's just sick and maybe have travelled anywhere, consider that if there's not another diagnosis or test there. So we are trying to make sure we don't fall into the trap of only finding where you look for, but we have to do that in a way that doesn't promote a whole heap of unnecessary tests, because that's wasteful of our resources, but also detracts the lab from some of the higher priority testing it's doing.
That's right, because the labs are actually quite overwhelmed at the moment. They're testing 24/7, so it is important to be as prudent as possible.
And I think if one GP starts to test people that don't fit the description, then definition, I think it will lead to a bit of a
and when I say, and when I'm giving permission for those extremes, I'm saying at the margins, if there's a particular reason that there's something unusual about the story or something. You can also talk to your public health unit. So if you're really finding it hard, because it may be that some of the family, because people are coming back and indicating linkages with other people, or I've been on the plane, so you can verify some of this by contacting public health, because they will understand those family groupings or who's tested positive. And also probably the quickest way to allay their concerns is that most of the time we'll actually know that the person they think has the disease is actually negative, because, as I said, we've tested all those people, only found 4, and the 4 were almost 2 weeks ago now.
So to clarify, so if someone comes in, then being anxious about it is not enough to just go testing.
That's correct.
It still means you need to have some good reason behind what it is that the anxiety is, and there needs to have been some link in some way that does give them some potential to have been infected.
That's correct. So, for instance, if someone had come back from Japan, or said I've been exposed to something, or another country where they had been exposed to a cluster, unusual outbreak of respiratory virus,
or
everyone,
time with people from China,
and that's right, who had moved, who had got out, or in Korea, and if you're using the epidemiological investigation skills, and there's something about this that warrants it, yes, but we have to be really prudent, because I just like to acknowledge the fact that the labs are doing it. And what I'd suggest in those cases is, before actually doing it, is just talk to the public health unit, because they may well be able to say, no,
you
that's
really
not
don't need to
do, or that's actually based on a rumour, that person didn't have it, or we've already cleared that person, so it's fine.
There's another question that relates to that, actually. Someone's asked, people do it privately? Can they pay to have the swab done?
No, the only places that are doing this testing are our public laboratories, and we are scaling up access to our public laboratories in preparation should we need to scale up testing even further. So I think the plans are for the Liverpool, RPA and North Shore labs to be brought on board. We've currently got testing at Westmead and Randwick. So we do want to strike this fine balance between making sure we're not missing any cases, but being prudent in our use of laboratory testing. But at the moment, there is no private testing available.
Can I ask this, and this has come up previously, but I think it's really important that we cover it. Someone here has said, I trust my patients, and when they inform me they've not travelled and have not been exposed to possible contacts, I've issued certificates to state they're safe to return to work. Is that okay?
Well, if that's to your best of your knowledge, I mean, a GP's got to make a professional judgment, based on the advice. But anyone we've told to go into home isolation should, and we are calling upon people to comply with that. So again, if you've got any concerns as a GP about who's in front of you and what they're asking, we again would like to talk to public health. But clearly, if your patient's actually saying to you they didn't travel, why are they being asked to give a clearance certificate as well? And if that's the case, we'd also like to hear about those in the public health units, so we can actually knock this on the head that clearance certificates are not things that people need. And there's no utility, and it's wasteful.
Yeah, I must admit, I find that the idea of giving a clearance certificate is a little bit tricky, because, as we said previously, we can't predict what's going to happen. I mean, we could...
Yeah, so what I was saying is that the case scenario you gave, just to be clear, is that the person actually hadn't moved out of Australia or hadn't travelled. But what I'm saying is I'd like to hear about those, because that's a really absurd behaviour from a business to actually require a clearance certificate of someone who has clearly not travelled. So it does there's a bit of disconnection there about why is the business actually asking for that. And we would like to correct that, because I think there's so much misinformation about this. It's an opportunity for our public health units to actually do a little bit of education of that business. So please let us know.
I've got some questions that have come through, if I could jump in. This is something that we have already addressed, so if I can, Kerry, I would just like to confirm that what we have already said is still the current advice. So there's been a lot of questions still coming through about PPE gear. So previously we had said that if GP is taking samples on patients with mild symptoms, that they should use standard contact and droplet transmission precautions, so long sleeve gowns, gloves, protective eyewear, face shield and a surgical mask. And if taking swabs from patients with severe symptoms, airborne precautions, including P2 masks, are required. And if there's severe symptoms, they should be referred to ED for testing. Is that still the advice that New South Wales Health is going with?
So yes, and what we'll do is, let's just repeat it again so your listeners are really clear. We will circulate the summary that Kathy Dempsey's provided, and probably that's the best reference.
So they are actually currently on the website. So there's a link from Ministry of Health. There's an infection control tab, and it goes straight to those pages. Now I have renamed those today, so they're a little bit more intuitive, and it says infection control in primary and community care. So they should be easy to find. But basically, if you're faced with a patient who is routine care, is relatively well, then it's contact droplet, aerosol generating procedures, or critically unwell, airborne, and that's where we would be recommending that you would send them through to hospital to be tested.
Great. And we've had some concerns come through that our case definition for travel is different compared with other countries. And obviously the recommendation is from mainland China, and there's some people concerned that internationally, for instance, from the UK, they've also included Malaysia, Singapore and Taiwan, and are asking if there is a reason, if we currently have a reason for that difference.
So the Communicable Disease Network Australia is actually considering this, and I think I've alluded to it in my previous conversation. So this is around looking at either countries that are reporting increasing numbers or countries that potentially have not reported cases that you would consider, given the travel patterns, should have been reported. That's why I answered the previous question, which is where you think there might be a link, or you've got a suspicion, or you've got some history, then we are happy to have that broadening, but we can't have open the floodgates to testing more, because then that doesn't allow the labs to focus on the key groups. It may be over upcoming days that as CDNA considers the information coming out, that we actually create a list which is around some other countries to consider, but that's currently in progress. And I'm sorry there's a lag, but we have to be very thoughtful in considering and seek the advice of CDNA that's doing that. But that's why I'm also giving you that flexibility to use clinical judgment if there's something coherent about the story they're giving that makes you conclude it.
So in principle, you would think about another country if there appeared to be the origin of infection from that country being transferred to a third country. And that's really what we're thinking about at the moment, but it's not every country thinks quite the same. And so there may be some variation between different countries, but fundamentally the problem is China.
And we've got some people sending through questions. Obviously, patients are going to their GPs that have travel coming up and are quite concerned. What is the, standard advice to GPs to give their patients who have patients that want travel insurance certificates when they're not travelling to mainland China? So the advice for travel not to mainland China.
So I think that this is a really difficult area for GPs to provide advice from, and I would be referring travellers to the SmartGov Australian government website, and that's because that actually is the formal travel advisory. So I'm not sure, because I'm not conscious of what travel agents would do or what the obligations, but clearly current travel advisory is don't go to mainland China. And so I suspect that would, if you went to mainland China, that may have implications for the validity of any of your insurance, or at least prompt you to get your patient to explore that. There may well be exceptions in extreme circumstances or for other things. So I don't know that you as a GP can have a crystal ball. If your patient travels in 6 weeks' time, I would not be giving any assurances. All I would be saying is it's prudent to monitor the SmartGov website and that will be regular. Your understanding is that that will be regularly updated with the appropriate travel advisories. But give them general, if they're choosing to go, it's appropriate to give them the general advice about hygiene, hand washing. We know these things are transmitted from surfaces and through those routes, and so making sure that they're very clear about cough etiquette, thorough hand washing and the hygiene messages, and depending on the specific country, protecting them for the other things that they might be at risk of in those countries.
But it might be prudent when seeking insurance, because I've been in this position myself, to make sure that it does cover in the event of not going. And the reason for not going might be because the country cancelled the conference you were going to because of the virus. But just be sure whatever form of insurance you've got for travel will cover that, or understand I don't know if there's any cover from the government for that purpose. So just make sure your own travel insurance assures you that you'll get reimbursed if there's a reason that you can't travel.
And also just be careful about the exclusions. Like, we're not experts on exclusions, but there may well be, even if you're quarantined, it is deemed not covered explicitly by your insurance. So I think it's best to not try and proffer too much advice in this area, and refer to the SmartGov website.
Awesome, and I've got a couple of questions around symptoms and transmission. The first one is a question that has been asked. I will just, as I did with the PPE gear, confirm. So there's been a couple of questions around transmission via the fecal-oral route. Previously we had said that, as Kerry said, we're still learning, but available evidence suggests that respiratory droplets are the main source of infection. But at this stage we can't rule out the fecal-oral transmission. Is that still what we're going with?
I think that is still the case, although I would point out in the Australian cases that I'm aware of, it's not been detected in the stool.
Sorry. And I've got two eye-related questions. There seems to be some concern about an article that has been circulating that suggests transmission can occur through eye membranes. Do we know if there's any validity to that at all?
I'm not aware of it. Have you heard anything, Kerry?
But I suppose that goes to...
Unless there's
It's from an
droplet.
infection control perspective where we consider that any mucosal is a potential risk to exposure, and we just protect those areas, but nothing specifically around, if you've got a conjunctivitis or anything, whether that's
No, of
increased
course. So it's
risk,
like
so
if you get coughed on
yeah.
and it hits your conjunctiva or your face, then potentially it's transmissible. Is that what you mean?
I think that's what they mean.
Yeah, and thank you, Kathy, for mentioning conjunctivitis, because we had a couple of questions come through saying that ophthalmologists had been advised that that was potentially a risk for coronavirus or a side effect of coronavirus. So that's a no on that one. Awesome. And there's also been a couple of questions come through regarding if there is any statistics of the fatalities that have occurred. Do we know the percentage of those fatalities that have had co-infection with other things like influenza?
No, is the short answer.
Okay, perfect.
But in terms of looking at co-infections, I'm not aware of how frequently that's actually tested in China.
Yeah.
But in our experience, the incidence been extremely low. And in fact, just one family group was quite interesting because the husband and wife both had similar symptoms of respiratory infections. One had paraflu and the other had coronavirus, but they didn't have them together.
That's actually one of the other questions I noted coming up. Someone's asked, is it possible to tell the difference between coronavirus and influenza?
Not clinically.
And there is another one in terms of infection rates, how infectious it is. Is there any data on that compared with things like flu?
The short answer again to that is no. We need to know more about the biology of the virus. One thing I can say about flu is that the peak period of infection is in the 24 hours before you become symptomatic. with coronaviruses, and we believe with very rare exceptions, it's the case that you're infectious when you have symptoms, although those symptoms may be mild.
That's the main themes of the questions that we've got here. For the people online, there is some stuff that's come through that we haven't responded to. It's because it's previously been answered. So if you have a look in the handout section of your control panel, there is an FAQ document in there that has answers to a lot of these questions and links that you can be directed to for further information on those things as well. Was there anything else, Penny or Charlotte, that you had seen that you
I was
wanted
just
to
wondering
address?
whether we did have a question that we didn't get to last time, which was around treatment and just maybe
Yep.
emphasising
Yeah.
what treatments used, the supportive care, but also talk about maybe in the more critical issues that you're looking at in critical care, what drugs might be useful.
Yes, so at this week, in fact, we're planning a teleconference of infectious diseases, ICU and ED experts and a respiratory physician to just consider a common approach to therapy. It's quite clear that there is no proven effective therapy for this particular virus, and that in mild or moderate cases, symptomatic therapy is the preferred treatment. You may get pressure from patients who have been in China that some of the Chinese patients are being treated with a combination of other antiviral drugs. The first point to note is that Tamiflu has no effect whatsoever. It's effective against influenza. The second point is that they have tried an antiretroviral combination called Kaletra, with or without ribavirin, but there is no clinical evidence of benefit with this particular coronavirus. The reason that those have been at least considered relates to really some preliminary and in vitro data around SARS and or MERS, but none of them have actually been proven in clinical situations. Nevertheless, I think if someone is critically ill or is rapidly progressing, then all of us have a tendency to try anything that even might have a possibility of working. There are clinical trials going on, and in fact there is a new drug called remdesivir that is made by Gilead, which they are sponsoring as part of a randomized controlled clinical trial in China, which is being compared against a combination of therapies which do include Kaletra and ribavirin and, if I remember correctly, interferon. But that's as much as we know at the present time.
And I suppose just to indicate that when we say there's no specific treatment, supportive care and the high level of care that we have in the Australian healthcare system will obviously is very critical to the recovery of many patients. Yeah.
Thanks for answering those questions. That does bring us to 8 o'clock, and we have once again, of course, run out of time and not been able to address all the questions online. What I would suggest that you do is please have a look at the FAQ that's in the handout section of your control panel. If your question has not been addressed in there and online, I've just posted an email address where you can email your question through to us. I would also like to thank our panel again, Charlotte, Penny, Kerry, Kathy and Tanya for joining us, and we will continue to provide you with updates as they become available to us and keep you updated on the current situation the best we can. So thank you everybody for joining us.
Good night.
Good night.
Good
Good night, everyone.